Good morning. I'm Dr. David Maloney from the Fred Hutch, and I'm here with Dr. Mary-Beth Percival, and we're welcoming you to the Hematologic Malignancies panel discussion. So I would invite you to please put questions in to the chat, and we will get them and have a chance to try to interact. So let's start off maybe first. I'm gonna ask Dr. Percival some comments about the Zuma 3 trial. So this, from my perspective, it's really exciting to see a product getting closer towards approval in adult ALL. Of course, we have tisagenlecleucel approved for pediatric young adult ALL, but that stops at age 26. And so it really is horrible when you're in the clinic and you have a 27 or a 28-year-old and you actually can't prescribe tisagenlecleucel. So it's great to see the Zuma 3 study come about. Can you just tell us your thoughts on the study?
Yeah, thanks, and I'm happy to be here. And please, just to reiterate, it's going to work best if we get your particular questions. So feel free to put those in the chat. Yeah, so I think that this is such an interesting study because of the limitations that you had talked about before with the previous CAR T therapy. So I just was looking up because I wanted to make sure the age, though the median was 40, which is already significantly older than the young adults, there was even up to an 84-year-old. I knew it was old, but I wanted to check. So really, this is like the spectrum of ALL patients that were included in this study. And about half of them had a prior transplant. So it's really a group that had poor responses and really were in need of other therapies. So I think that having that available and having demonstrated efficacy, and I think there are always limitations with some of the cell production and things like that, but it didn't seem like there was any more of that than in other previous CAR T studies. So I think it's a really exciting alternative that will hopefully soon be available for our patients with relapsed refractory B-cell ALL.
Yeah, some of the earlier CAR T cell trials in adult ALL were actually stopped due to toxicity, and particularly with cerebral edema and neurologic toxicity. And that was also seen with this product to some degree.
Yeah, it was not I wondered a little bit as you were saying that also, how in particular, when we get more information that's not just in abstract form, like in a full publication, what we'll learn about some of the patients and whether they'll do an analysis to see if some of those toxicities were greater in the older age group, for example. It's a relatively small study still overall, so they're not going to be able to slice and dice the data that much, but being able to do some either pairwise or even maybe a multivariable analysis to look at outcomes, I think would be really important. But you're right. I mean, like 90% of patients had CRS. So it's certainly something that was seen. And then there were a lot of patients, about 60%, who had neurologic events also. So it's not toxic, but I think balancing that effectiveness and toxicity is a really a hard balance for a lot of different drugs. What are your thoughts, David, in comparison to some of the other CAR T therapies, maybe for lymphoma or myeloma, that are available now in terms of that profile?
Well, this CAR is actually based on axicabtagene ciloleucel, which is it's the same construct, but the only difference is that there's a relative purification step beforehand to essentially eliminate the malignant cells. So there's a B cell depletion step, but the construct is the same. So it's not surprising the toxicities are pretty similar to what we saw with axi-cel, but it's also there's very ready access to the tumor cells in ALL patients, and we know that when you give these CAR T cells, they don't take a long time to find a tumor, get signaled, and then can grow and proliferate and cause toxicity. But I think this is just really exciting that we're going to have a potential option for adults, and hopefully that'll move forward. I want to just mention that the abstract I thought that was the most enlightening in the lymphoma group. Well, there were two of them actually, but one of them was the comparison of Acalabrutinib with Abrutinib. So this is kind of the second generation with Abrutinib, and it was really set up as a non-inferiority trial. And it actually met that in a very large study. The hazard ratios are absolutely identical in terms of progression-free survival, but where it seems to have won in is that it's less toxic. And it seemed to decrease the significant cardiac toxicity with atrial fibrillation or atrial arrhythmias, as well as some of the bleeding and hypertension. So it decreased, and as a consequence, there were fewer people that came off study because of toxicity. So, I know in our center and in my practice, I'm moving more towards using Acalabrutinib in most settings. I think that the dilemma is, do we extrapolate from the relapse refractory setting to the frontline settings or not? And I think that I probably will in my practice as long as we're able to.
Sometimes the insurers have opinions about that as well. So I think that's going to be another hurdle to potentially face.
Yeah, and that's why people are asking the same question about Zanubrutinib, which also has some positive data and randomized studies in Waldenstrom's against Abrutinib. And they're the same thing where the less toxic BTK inhibitor appears to allow people to stay on treatment longer and achieve deeper depths of remission because of that. So,
I see a question in the chat, Dr. Maloney, that says, what is the mechanism of the BTK inhibitors in causing cardiac toxicity? And obviously you just mentioned potentially switching drugs, but the question also says, any strategies or medications to help reduce the risk, potentially beta blockers, something like that. So I don't know if, maybe Acalabrutinib isn't available for a particular patient, what you might recommend if somebody has cardiac toxicity with Abrutinib.
Yeah, I mean, that's a really good question. And if in my practice, I've been actually avoiding BTK inhibitors in people who I'm going to have to start on anticoagulation because of atrial fibrillation. So in the front line, I try to avoid it. In people who have major bleeding episodes, such as subdural hematomas, I've been actually stopping BTK and not starting a second generation one. As far as what is causing this, I don't think we know, but there was another interesting abstract I saw at, I believe it was ASCO, where they looked at SNP analysis to see if they could predict who would have cardiac toxicity from Abrutinib, and they've actually found 3 or 4 SNPs that seem to be correlated with cardiac toxicity. And so I don't know the mechanism, but it sets the stage potentially for being able to identify, patients at risk, and then maybe you would want to start off in that setting. But I think that the patients generally feel better. I mean, the major risk with Acalabrutinib that people complain about is headaches, and but most of the time you can have people drink coffee, and within a month or so they're better, so they're awake for a month. So it seems to take care of that.
I blew the mind of an intern on inpatient leukemia rounds when a patient was complaining of headache and they had a very long differential. And then I went in the room and asked the patient how much coffee she drinks outside of the hospital. And she said, 4 cups a day, but I haven't had a drop in the hospital. Anyway.
Yeah, there you go.
So, great drug, caffeine.
Yeah. So Ponatinib had some exciting data. Why don't you share that with us?
Yeah, so of the abstracts that I discussed, I think that is actually probably the most practice changing among the leukemia abstracts. So it was the abstract for CML patients who had failed one of the TKIs or had the T315I mutation and needed to be on a next generation TKI. I guess you can call Ponatinib a 3rd generation TKI. And, there's been a lot of toxicity with Ponatinib. It was approved to kind of great fanfare about a decade ago, and then pretty quickly got a black box warning and was actually unavailable for a period of time because of all of the really devastating arterial clotting events that happened, about a rate of about 20%. And so, even though it was very effective at putting these refractory or relapsed CML patients into a molecular remission, there was this kind of side effect of toxicity. And so I think, there's always a question similar to this kind of, cardiac toxicity question with Acalabrutinib and Abrutinib, but what do you do if you have somebody who has any kind of cardiac history? Is it worth the risk when they have relapsed refractory CML and so few options to put them on ponatinib? And so in this study, they took patients and started them at this 45 milligram dose, which is the typical dose, and then waited to assess the response, and then were able to down titrate the dose to 30 or even 15, kind of depending on the way they allocated patients in the groups. And the responses were great. They were best in the group where they started at 45 and then were able to decrease the dose once a response was achieved. And the rates of those arterial events were much lower. And so I think it's really, of all of these things that are, whether they're ready for prime time or not, I think this is something that can be put into practice immediately for patients that need to start ponatinib. So I know that, there are many patients who fortunately don't need that and are able to respond to switching to a different drug. But when you get into that situation of needing to start ponatinib, I think that now we have a way, a regimented way to decrease the dose and really minimize the long-term toxicity.
There's also a question here in the chat about enasidenib and azacitidine, and as would you do this in de novo MDS patients? Sure
Personally,
insurance, right?
Yes, I know, and I see that they say assuming they don't have access to trials and insurance will pay for it. I personally have not done that for an MDS patient, and I think part of that is these targeted inhibitors sound really great, but there are limitations that are outside even this idea of being eligible for a trial or having insurance pay for it, which is, the rate of IDH mutations is probably about 10 or 15% in patients. So it's not like the most common abnormality, though certainly it does increase in frequency as patients get older. So I think it may have a role. I personally am a little bit cautious about enasidenib because of the trial that was stopped about a year ago called the Identify, so the IDH Entify trial, which randomized patients to getting enasidenib or enasidenib plus azacitidine. And all that we know so far is a press release from the company saying that the study was stopped due to lack of efficacy. There hasn't really been any more formal data. And so that just makes me always wonder, if our backbone isn't so great, maybe that's a problem. Azacitidine is a standard, but is it the greatest thing since sliced bread? I think most people would agree that it's not. So maybe it's a backbone issue. Maybe it's a synergy issue with the enasidenib and the azacitidine not working well together. But it does make me want to make sure that we are not just diving headlong into a molecularly targeted world because we can, more maybe because we should. And I think there are varying degrees of evidence behind some of these molecularly targeted things in AML and MDS. But I see there's some questions about, I know you also wanted to speak about the Hodgkin's study using BIACOP, and BIACOP, speaking of toxicity, is a notorious regimen. So I think that maybe if you could talk a little bit about providers who aren't comfortable ordering BIACOP, but then also sort of why you would, and maybe should they be at an academic center, and that sort of thing may come up as well.
Yeah, so I think this was a really key abstract that probably will be practice changing in the area of Hodgkin's lymphoma as well. There was an earlier study that just looked at patients with unfavorable Hodgkin's, but early stage, where they received 2 cycles, and if they had a PET negative response, then they continued on therapy with ABVD. But if they were still positive, then they had 2 cycles of BIACOP. And in that setting, that seemed to narrow the difference between those 2 groups, the people who were PET positive versus PET negative, by the escalation to 2 cycles. Now, this study that I specifically talked about this time was a little bit different. It took bulky disease patients. So these are patients with a bulky limited stage disease. And they also did a PET scan at 2 cycles. but then randomized to either, if they were negative, then they continued ABVD, and if they were positive, they got 4 cycles of BIACOP. And the interesting thing about this study is that the groups are absolutely identical at the end of the day. So by escalating, even in these bulky patients with positive PET scans after 2 cycles, you had the same outcome as if they were PET negative. In fact, that's better than the more limited disease, non-bulky patients. And so I think that unfortunately, we need to get comfortable with giving these aggressive regimens because it clearly seems to improve outcome. Now, that's not the end of the story, as you said, because I'm probably fueling your AML, secondary AML MDS clinic, as you see this from patients getting aggressive treatment. And so I think it'll take some time for this to settle in, but I think in these very bulky disease patients, this is suggesting that escalation does potentially have a role.
And there's a related question here, which I think you maybe didn't quite address. It says in early stage Hodgkin's lymphoma, status post 2 cycles of ABVD with interim PET negative. So not those patients where we're going to the 4 cycles of BIACOP. Is there any additional role to continue additional ABVD over XRT?
I think it becomes a little bit of a philosophy at this point. If you're and what you're trying to radiate, if you really look at the outcomes, they become quite similar, whether you use chemotherapy or extended chemotherapy or chemotherapy plus radiation therapy, and there's almost no change in survival. So in some of these, it becomes, what do you want to do to try to minimize long-term side effects at the risk potentially of some relapses? And then, of course, we do have other agents now, and that's for these patients to treat with brentuximab, for example, and checkpoint inhibitor antibodies. And so I think more likely it'll be incorporation of those agents into earlier stage disease as an approach. I want to come back to CAR T cells just for 2 seconds, just for a couple of seconds, since I'm obviously interested in this as well. I noticed that many patients, or quite a few patients, had blinatumomab before they got CAR T cells. And what's the thought in the leukemia group about targeting the same antigen that a CAR T cell is going to express? I know it makes me nervous.
Yeah, no, I think it makes everybody nervous. I think, there are many mechanisms by which ALL can escape immune regulation, and loss of the target antigen is one of them, but it's not the only mechanism. So, I think blinatumomab has been around for a while, but more recently we have the anti-CD22 targeted inotuzumab ozogamicin, which is also highly effective in patients with relapsed or refractory ALL. So, they obviously have to have that antigen as well, and most do. So I don't know. I think, unfortunately, you can't always plan what's going to happen. And so it's hard to withhold what is a very effective therapy like blinatumomab if the goal is to try to get somebody into an MRD negative CR, maybe so that they can go on to a transplant. But if you think that they may need CAR T cells in the future, should you not give blinatumomab and instead try inotuzumab or another cycle of standard chemotherapy? I don't know. That's a very tricky business to be in, because it actually reminds me of at our PCC transplant conference. You may have been at this one. It was a couple of years ago, but there was a patient who was trying to get eligible for a CAR T study. And at that time, there were no MRD positive CAR T cells. And so they had to have over 5% blast or some other site of disease for their ALL. And so the patient wanted to be relapsed rather than to have MRD level disease. And I don't know. I planning for that seems like you're just on this razor's edge of being able to fall off into a disastrous area that you can't come back from. So I think it's very challenging to withhold an effective therapy when you think that somebody might need something else in the future. And I see there's another question that's sort of related to that, and then I do want to talk more about CAR T cells from your perspective, because you see these patients more than I do. I see them sort of before and after. But this says, for a young, fit, not an elderly, Ph positive ALL patient responding to chemo or blinatumomab plus TKI in MRD at the conclusion of therapy, do you still recommend transplant? And I would say in general, we do still recommend transplant. MRD positive disease is very tough because patients with ALL, with AML, they don't do as well after transplant as patients who are MRD negative. But I think their outcomes without transplant are poor. And so, if it's a quality of life thing and they want to try to maximize the TKI for as long as possible, I think that's fine. But these drugs are usually not completely benign on their own. I mean, blinatumomab is certainly a very cumbersome medication to administer and can have a lot of side effects, particularly during the first cycle. But I think, generally, if patients still have evidence of disease, then I think that going to transplant makes sense. There's some pediatric data that suggests that the Ph positive ALL patients may not may be able to be maintained on TKI for a lot longer, but I think that there are differences between adults and children, and the rates of Ph positive disease in kids are so much lower that I'm not sure it's really comparable.
So to follow up on that, if you had that same patient, would you consider giving them a CAR T cell if it was available?
I would consider giving them a CAR T cell if it were available, because I think that, and then I know your follow-up question is going to be, then would you send them to transplant if they got into a remission with their CAR T cell therapy? And for an ALL patient, maybe not, but probably yes. And then for an AML patient, should we be in the fortunate position to have CAR T therapies that are FDA approved for AML patients, I think certainly the answer to date would have to be yes, based on some of the experience that people have had with some of the AML targeted CARs.
I think these are really great questions to try to debate, and unfortunately there isn't a lot of data in some of the areas. For the targeting CD19, there have been several studies in lymphoma and a little bit in ALL that suggest that the response rates at least are about the same in people who've previously been treated with, for example, CD19 targeted agents. But that's not really the end of the story. I really want to know, what are the duration of remissions in those patients? What's the plateau on the curve in lymphoma? And that really hasn't been as presented. I mean, people just say, well, here's the response rates, and yes, there are some CRs. So I tend to try to avoid targeting the same antigen if I can. Now, as these agents move up into the frontline setting, like if you're adding blinatumomab to frontline, then you have to give it. I mean, those are, I agree with you 100%. But I think if you have an opportunity in the few months preceding CAR T cell therapy to avoid targeting the same antigen, that's probably a better idea. We know that the half-life of the antibodies targeting CD19, are in the 30-day range, not maybe the bispecifics, but the naked antibodies, and so, such as tafasitamab. So the question would be, do you have to wait 100 days or 200 days, to target? And so I just try to avoid that. And
I remember this question coming up a few years ago, also with some of with the idea of CAR T and transplant in some of the anti-PD-1 inhibitors. And, should you wait? Were you going to sort of increase toxicity of some of those therapies after, kind of manipulating the immune system in one way and then trying to manipulate it again? So I don't know, we may have more answers soon with more experience.
And then the question of transplant is really a great one. And, in lymphoma, I typically don't transplant patients because there seems to be more of a convincing plateau on the curve, at least in diffuse large B-cell and the aggressive lymphomas. In ALL, our policy really at the Hutch and the immunotherapy group has been, if patients have not already had a transplant, then to refer them for a transplant if they can get into a MRD negative remission post-CAR T cells. The Sloan Kettering group did this, where they looked at the transplant or not in their group that they treated with CAR T, and they couldn't show a difference, but they had a pretty high non-relapse mortality in the groups, and it makes it very difficult to figure that out. In our group, it looks like if you can do a transplant, you do better than if you can't. But that group is very self-selected, because in people who've already failed one transplant, our enthusiasm to go to a second or third transplant, goes down because the toxicity goes up, and I think they're tremendously intertwined, and it's very difficult to really answer that question. But seeing late relapses in ALL after CAR T, at least in the adults, we generally would recommend a first transplant if you've not had one. In pediatrics, it's a little bit different. In the Alana trial, it looked like, patients were cured, and patients are out many, many years now in some cases. So that's our kind of policy. You probably see that a lot more in the leukemia group about what to do with these patients. And now we need a CAR for AML. So
yes, I think that there are a lot of people trying to do that. We spoke a little bit about targets and target choice in ALL, and CD19 is sort of the winner for the most of the CAR constructs. But I think that it's more challenging for AML. And so CD33 is commonly expressed on myeloid blasts, probably 90 to 95% of the time. CD123 is another commonly expressed target antigen. The problem is, among others, is that they're expressed on other progenitor cells as well. So that's one of the biggest problems is, maybe if your CAR is too effective, you may really ablate normal marrow. And so you're not going to have recovery of hematopoiesis in the same way that you would after a lymphoid directed CAR. So I think that, transplant is really going to have to be part of the policy. I know one CAR trial that is being developed where they are making sure that patients have a donor lined up in case they need to go to that more quickly than they would expect to. So, I think it's something that we need to be very thoughtful about. And really, especially in the early days of CAR for AML, making sure that the patients are selected to be able to tolerate the rigors, but also able to move on to a transplant if necessary.
Yeah, I think in ALL, at least in the pediatric setting, most of the patients that got CARs had already failed an auto transplant in the young adult setting. So again, I guess there's more enthusiasm in the pediatric groups to do second transplants than in the adults. But I think it's going to be very exciting to see this move forward. There's one more question in here. I had mentioned that the non-bulky stage 1, 2s did poorer than the bulky ones. And I think the reason for that was in this trial I talked about today, they actually got 4 cycles of BIACOP if they were PET positive, where in the other study they only got 2. And so what it suggests is maybe in the more favorable but unfavorable patients who were PET positive after 2, we should give them more BIACOP than just 2 cycles. And so it'll be interesting to see whether that gets followed up in any clinical trials.
I do see one other question that is sort of the idea of switching from Abrutinib to Acalabrutinib. So it says in patients with clinical CR to Abrutinib and CLL or Waldenstrom's, et cetera, with AFib but no bleeding complications, would that be a reason to consider switching to Acalabrutinib?
Yeah, tough question. I don't really know the answer, and it becomes down to individual practice. I typically don't start Abrutinib in patients with AFib or with a history of AFib.
What about if they were to develop AFib?
Yeah, then I often, it depends on the scenario. And this is exactly it. If it's mild, early, kind of low grade, and they don't require intensive anticoagulation, they didn't have a stroke or some other complication, then I could leave them on it. I have not switched anybody to either Zanubrutinib or Acalabrutinib yet. it's, it's not like there's no atrial fibrillation with these other agents too. And so if you have a patient already prone to atrial fibrillation, I'm not sure that switching is going to completely solve a situation. I mean, I guess if you had a patient that had transient AFib, got put right back into sinus rhythm, and was never another issue, then you could consider it. I often will be thinking about switching classes of drugs if it's a real problem.
Like to a venetoclax-based regimen, or what would you sort of move to
usually,
next?
I mean, that's the other approach, is to do a more either time-limited therapy or venetoclax or obinutuzumab as the therapy, in which we would typically do in someone with bad cardiac issues or atrial fibrillation from the beginning. Let's see, what else on here? What else do you want to just mention about AML? Anything of excitement here?
I don't think it was the most exciting AML series of abstracts. So AML is not because AML isn't exciting. It's very exciting, and lots of things are happening, but maybe they weren't all reported at ASCO this year. So there was, I think one group that we always think about we've spent a lot of time talking about fit patients with all of these sort of regimens that we've been discussing, but maybe for less fit patients. So there is a drug, a cytarabine construct called aspacytarabine, which maybe coming forward, it's gotten some breakthrough designation by the FDA. And so we'll have to sort of see as more patients get enrolled and as the trials are expanded to include patients with different levels of disease. So yeah, that may be something else to keep an eye out for.
All right, well, thank you very much. I think we actually ran out of time, so we can wrap up here. I want to remind everybody that up next is a break. Please interact with exhibitors, earn points, try to win your free prizes. And it's a delight to be here, and have a good afternoon.
Thanks very much, everybody. Thanks, David.